evening, everybody. It's 8 o'clock, and welcome to today's episode of Marvelous Medicine. The title of the session is Bioethics and Research in Healthcare. The speaker is Dr. Nalin Mehta, Director, Northeastern Indira Gandhi Regional Institute of Health and Medical Sciences at Shillong. Nalin did his MBBS and MD Physiology from JIPMER Pondicherry and a Masters in Bioethics from the University of Toronto. And he's a PhD FEMA Regional Medical Education Fellow. Nalin was the first Indian civilian doctor to winter over for 16 months in Antarctica for human physiology research. His special interests include medical education, bioethics, research methodology. He has over 80 research publications and has delivered several invited lectures both nationally and internationally. Thank you, Nalin, for offering to do this topic, and welcome once again.
Thank you. Thank you so much.
Moderating the session will be Dr. Shefalika Goenka. She is the Professor and Director of Bioethics at Public Health Foundation of India. She is also the Head Physical Activity and Obesity Prevention Center for Chronic Disease Control, WHO Collaborating Center for Surveillance Capacity Building and Translational Research in Cardiometabolic Diseases. Dr. Shefalika did her MBBS from TN Medical College and Nair Hospital, Bombay, and her PhD from the All India Institute of Medical Sciences, Delhi. She established the Ethics Committee of the Indian Institute of Public Health, Delhi, and is a member secretary of IECF CCDC. She has over 70 publications to her credit. And thank you so much, Shefalika, for readily accepting to moderate this session at such short notice and for all your enthusiasm and feedback. And I must thank Dr. Krishna Kumar, pediatric cardiologist from Amrita Institute, Kochi, who put me in touch with Shefalika and suggested that I should ask her to moderate the session. Over to both of you.
I think we could do with a talk from Shefalika about that obesity you mentioned.
No, sir. So it's a privilege being here, and thank you for inviting me. It's a true privilege to be part of this group and a very dynamic group. And so all the floor is yours, sir, Dr. Mehta.
Thank you so much. I have also learned how to share screen. I forgot to say that. So what we are going to do today is I have this little presentation which Vidya said is important. Otherwise, the discussion doesn't go on. We'll talk about ethical issues in healthcare and in research. And the rules of engagement are very simple. Now, some of the screen, yeah. There are no rules. We just maintain audio and video etiquette. And if anybody has a question or a doubt, the moderators may please entertain them. Somebody needs to be reading the chat. And let me tell you, there are no stupid questions. Some of the finest answers come to them, and there are no ready answers. Ethics doesn't have ready answers. They're just processes. And if there's something you think I have missed or overlooked, please feel free to join and, update. So I'll talk about ethics, then I'll talk about research and evolution of research ethics. It's important because animal ethics has predated human ethics. Then we'll talk of the basic and general principles of modern day bioethics as per the Indian requirements, because there are a whole bunch of ethical guidelines, right? From NIH has their own, CIOM's guidelines, the Tri-Council policy, and ICMR has a very robust guideline, which in the International Conference for Harmonization, it was appreciated a lot. And at times I personally feel that they are a little tough guidelines to handle. So if you can follow the ICMR guidelines for biomedical research on human subjects, then there's a separate guideline for pediatric age group and a separate guideline for animals, separate guidelines for stem cell research. If you can follow them, then I think you've done a very, very good job. Then we'll talk about basic and general principles, because the modern day bioethics is principles-based bioethics, and everybody would know the 4 pillars and the general issues. Then we'll touch upon the ethics of healthcare delivery. And unfortunately, like we have the biomedical ethics guidelines from ICMR, and there are research ethics guidelines and IRBs and ethics committees all over the world, we do not have a set of very, clear-cut guidelines for clinical care or healthcare delivery. We have a code of conduct. National Board of Education gives one. The National Medical Commission has come out with one, but there is no clear-cut, ethical guidelines. And of course, if there are questions, we'll be very happy to stumble and stutter and stammer and try to answer them, whether we can or not. That little cough which Vidya said was a cough was actually a roll of drums. I'm very impressed by Humphrey, who said that the moral test of any society is how it cares for the people in the dawn of life, the kids, then in the twilight of life, the elderly, and those in the shadows of life, the sick and the disenfranchised. And we deal with all of them. So I think when you get up in the morning and you read the newspaper and you have some sickening news, the society still needs to come a long way when it comes to morality. Ethics, on the other hand, Campbell et al. Have a reasonably mouthful of a definition. Says the subject of ethics is best thought of as a critical scrutiny of moral thought and morality as it affects our ideas of right conduct. So, when you talk of right conduct, which side of the road do you drive on? Half the world drives on the left, half the world on the right. We are not sure which is correct. So, basically, what it brings about is that there are different sets of ideas of right conduct in different locations. It may change within the same nation depending on the ethnicity of the population, whether we are dealing with vulnerable population like in the tribal belt, we are dealing with the socio-economically disadvantaged, and so on and so forth. But different countries have a set of guidelines which broadly can apply to the entire country with conditions. And ethics, unlike the brownie points you get from doing the good job, you've done your good deed of the day, ethics is a little different. I'll give you a very interesting example. If you see a blind man with a white cane and a red handle standing by your side on a very busy intersection, there is a tendency to help him cross the road. You feel you'll do good for somebody if you help him cross the road. Now, the problem is that you might not necessarily do him any good if he doesn't want to cross the road. So ethics is about that. Morals and values I'll come to, but ethics is about doing the right thing in the right situation for somebody who appreciates it then. And when it comes to medical ethics, it's far more complicated. Simply put, it's a reasoned process for dealing with a problem concerning what ought or should be done in a situation. And there is a very interesting thing. Let's take about one disease or deformity which is being treated by one doctor, and he has two patients of the same disease. Both the patients may not be treated similarly. It depends on the patient's choices. So then we'll talk about the principles of ethics. Then there are these, when I do an interactive session, the word morals crops up. Morals are basically societal constructs. These are in a society, and different societies may have their own moral constructs. And then we have a personal, thought process, or we have values are very personal. They may be a human being may have his or her own values, or a very small group may have their values. These are not societal constructs. These values are what affect people. Now, when you talk of ethics and policy and law, I think this is very important to, at this stage, understand. I'll start with ethics. Now, for example, I have, now, of course, my son is an adult. A couple of years back, when he was a teen, if he borrowed my car to practice, to learn to drive in the campus, he needed to say, please, Dad, may I borrow your car if you don't need it? And if you can help me learn, that would be a good idea. So the policy in the house is that he may learn to drive that car when I don't need it. And one fine day, I find the car is missing. I need to go to work. I get into trouble. So I can punish him by grounding him, not allowing him to, go out with his friends, etc., ground him for a week or whatever. Law comes in when he does the exact same thing with my neighbor. Now, without my neighbor's permission, if he borrows the bike or car, then it's not borrowing. The neighbor will call 100 or 911, depending on where it is. So what I mean to say is, whenever you are faced with a dilemma or a major ethical issue, a very simple example, you have one ICU bed and two very critical patients. One is an 18-year-old with a head injury whose GCS is way below 0, almost zero, and you have a 75-year-old person in failure after a bypass. Now, whom would you admit? You have just one bed. So people have a tendency, let's admit the youngster because he has a long life ahead of him, blah, blah, blah. Somebody says, okay, you see the youngster, his blood alcohol levels are hitting the ceiling. He has puncture marks on his elbow. He's a junkie. He's not wearing a helmet, so death wish. But still people say, youngster, let's try and salvage him. But the point is, who gives you that right to decide which one of the two will live? Then you get a call from a higher up, and your director calls you saying that somebody called up some minister, some this and that the old man is his relative. Then you are forced to admit that person. So these kind of ethical dilemmas a person on duty faces often, and all of us, you and I, we've all been through it. So in these situations, we go to what is known as the policy. A very good evening to Professor Nandi. How are you? You are mute. Can't hear you, can't hear you, you're muted. Anyway, so policies are in place in most institutions where they may say first come, first serve. So now that headache of admitting the patient, depending on, one bed and two patients, the headache is gone. You are following a policy. So the policies are basically there to help the healthcare delivery personnel. But first come, first serve may not be a very sensible policy. So then it comes down to a triage where a group of people decide who requires the treatment and blah, blah, blah. So I think you can have very robust policies to take this stress off the people on duty. And it's a given law when it comes to ethics is a recommendation. These are guidelines. You may or may not follow it, and you may or may not be punished. Policies you may, avoid, but policies are meant to save you. But law, if you're on the wrong side of the law, you're in serious trouble. And whether it is research or healthcare delivery, the laws that are laid out are very clear. And for example, PT&D, laws about organ transplantation. And when people say there are no laws about research, I think now is the time to take that misconception away from everybody. The Drugs and Cosmetics Act 1945 very clearly states that for research, you have to follow the national guidelines that have been that are out there and amended from time to time. So the ICMR is a national body. What they have is a set of guidelines which becomes de facto law because the Drugs and Cosmetics Act says that you must follow the national guidelines. So I think ethics is good business. Policies save you, but law is something you have to follow or you're in very serious trouble. So multiple issues about ethics, it's a very unusual topic. People feel, I don't need to be taught ethics. I am a person with good moral upbringing. I'm a good human being, etc. But like that blind man you have helped to cross the road who didn't need to cross the road, you may do something unethical very unwittingly, even in an attempt to try to be doing good for somebody. For example, when you patronize a patient, a paternalistic doctor-patient relationship where you tell the patient, don't worry, I know what's good for you, and this is what we will do. That's no more the way things are acceptable. It's not ethical at all. So you have personal and subjectivity there in ethics and in different places. And people have their own perception about morality. So ethics is a lot more than just the guidelines that are in existence. And let me repeat, I mentioned it already. The guidelines are primarily for research and for routine healthcare delivery and clinical ethics. We don't have too many to go by, especially in our country. And as you are working, your experience grows, so does your, ethical conduct. Doctors are in a very, very, tough position here. They wear multiple hats. They are friends, philosophers, guides, healers. People come to them for, all sorts of issues. So there is a procedure or an operation they have to do. They have to explain. They have to be under the stress of it and do it all ethically. Consent, we'll come to consent separately. When a patient says, do whatever you want, you are like God, then there are other issues. So slowly, ethics is becoming mainstream, and the National Medical Commission has now made it mandatory. Ethics is included in the ATCOM part of the competency-based medical education curriculum. I'll very briefly go about the evolution of research ethics. The entire business of ethics has undergone a very profound change. Not just the World War, even before the World War, there were some horrific incidents that happened. I don't want to go into the detail, but it would be a good idea to read about the Tuskegee syphilis trial. This was pre-World War. In the Macon County in Alabama, a whole bunch of research was being done on people with syphilis to study the natural course of the disease. Even when penicillin was discovered and it was being used, they were not given penicillin. It was horrible. I don't want to go into more detail, but please go through that. Then, of course, the World War II shook everybody, and then multiple, even the Willowbrook trial on mentally incompetent inmates. So these kind of events, forced a re-examination of ethical standard the world over. And then a consensus developed that we should not use human beings as a research, vulnerable people and people, high risk, low benefit research, you can't use them at guinea pigs to try something on them. Unless you have a good project, now that the ethics committees go through, and you've done your phase 1, phase 2, etc., animal studies, all that. So then you move on to human trials. In the 90s, however, the situation changed. We are all aware of thalidomide also, and how the company that pushed that drug had to pay damages. So now what started happening was, because damages were being paid for drug reactions and adverse drug reactions, etc., and compensation was sought for research accidents and adverse events that happened in research, the drug company started going a little slow to bring out a new molecule. They would go through all the animal experimentation, then follow very strict ethical standards. So this created a bit of an issue, because people with the fatal diseases, cancers, etc., they were up in arms. They were very upset with the go slow movement by the drug companies. They said, see, we are as it is terminally ill. But if you can try some molecule that you are developing, at best it will kill us. We are already dying. We are willing to take the risk. So then, people articulated their views. And after that, there was this ethical review system. So the business of ethics committees, etc., now it is mandatory. Every institution that undertakes human research or even animal, every kind of research, has to undergo a review process. And the review committee involves all stakeholders, including patient groups, people with from social, from NGOs, people with a religious background, scientists, lay persons. So everybody forms part of the ethics committee, and they discuss the ethical, the aspects of various research protocols that are submitted, and then decide whether the risk and benefit is weighed in the favor of the patient. So the patients have to benefit from the research and the risk is minimal. After that, permission is given. And it is now known and accepted, where the endpoint is death in, say, terminally ill patients, high risk is not considered as bad for a research to be undertaken. So the first step in the evolution of bioethics is a sense of solidarity with other human beings. Lovely words by Schweitzer. And we have this lovely image that had come in on the Time cover in 2002. So human should not be used as guinea pigs. This was in the wake of once the going got tough for the multinationals in the US and Canada and a few other, first world nations, the clinical trial venues turned out to be China, Brazil, India. India is a huge market for clinical trials. So all these companies started coming to India, China, and Brazil because it was easier to carry out, much cheaper to carry out research on our people. And those days, even the mechanisms in place were not very robust. For India specifically, in 2013, everybody is aware that the Supreme Court took a very, very strong view of clinical trials that were going on after the fiasco that happened in Andhra, the HPV vaccination informed consent issue. And there was one issue in Indore about in a pediatric clinic. So 2, 3 events happened one after another, and the Supreme Court banned all kind of clinical research. Almost 170 very big funded projects from NIH, WHO, and a whole bunch of other multinationals were all stopped. Then the Ranjit Roy Chaudhary committee came in. And after that, there was a very strong set of ethical guidelines that were made. And the compensation clause was very strict. Anybody who died and he or she was enrolled in a research project was to be given compensation. So this had to be modified because in the wording, it didn't come out that people who died of research-related causes. Like if I'm enrolled in a research and something to happen to me on a holiday in the Bahamas, I would still get compensation. So the wording had to be changed. And now the Indian Council of Medical Research has a very, very good set of guidelines, which were last amended in 2017. They're good to go even now. So now coming to the principles of modern day bioethics. So bioethics basically is ethics of each and every biomedical research that we undertake in our country. The first principle is autonomy, respect for the person, the individual, the institution that a patient is. I mean, you've seen it in that Munna Bhai. The patient is not a bed number or a disease, a case of this or a case of that. The patient is a human being. The patient has a right, and the doctor has to, respect the right of the patient. The patient has to take part in decision making about his or her healthcare delivery. Also, if they are participating in research, their views and their participation is totally voluntary. They may choose to participate, they may choose not to, or they may choose to walk out of research midway through. The second principle of ethics is it's a no-brainer. Do good. Every doctor has the efforts are to do good. But the third one is important. If you go into history of ethics, primum non nocere, the first of all, do no harm, was one of the main principles of ethics. To read, it was in Latin, primum non nocere. It means first of all, do no harm. Now, what are the kind of harm that you can do to a patient? Negligence is one thing, but negligence is basically something that nobody in their right senses would normally do. So these are rare cases. Negligent treatment is not very, very often. You don't come across. But errors can be there. Medical errors and negligence are two very different things. Second thing is a complication. There may be a complication resulting from a surgery or a drug treatment, which may lead to death. That also is not negligence. But the point is, there are multiple side effects, some of them fatal, that can happen following a procedure or following the therapy with a drug. You just don't go around telling every patient, you may have headache, you may have vomiting, the nausea, vomiting, diarrhea, coma, death, the kind we used to mug up in one. So you don't give somebody a paracetamol and say, there is a possibility that you may die. Now that will be scary. That's not ethical. That will be scaring the patient. But you have to, it's your duty to give them the details. So the harm is not just physical. It's not just death or deformity or disfigurement. The harm can be financial harm. It can be mental harm, societal harm. For example, if you start ordering, investigations for a patient which are not required, do an MR, do a CT, do this, do that. Patient is given a list of investigations. They may not be relevant for his or her condition. That is financial harm. If you do not keep the patient reports confidential and they are leaked and they are made public, that can cause social harm to the patient. One very good example of social harm that resulted from research was when the BRCA gene was published. I think this was somewhere in the 90s, Lancet. Yeah, it was a Lancet publication, and the result of the study, which was done on Ashkenazi Jews, was that an Ashkenazi Jew is a very good population to work on because they have very little variation. They are very, the lineage is very, very close. So what happened as a result was in the US, Ashkenazi Jew women lost their jobs overnight because the employer said we cannot afford to give their increased premiums for CA breast and all of them are going to get into trouble. So and again, they went to court, the decision was reversed, they had to take them and people were sued. So we have to make sure we do not harm the patient by, either leaking their report, or we don't leak it, being careless with patient data, patient reports, etc. And the justice, the fourth principle or pillar of modern day bioethics is justice. And this justice has nothing to do with law. This is equitable justice. This is distributive justice. Distributive justice is where the resources that are available are, the patients have to be treated with, equality, equitable. The resources I have should be available to every patient rather than patient who is rich or poor or somebody whom I know. So there should be no, unfair practice followed in treatment of a patient. The resources that are available should be made available to all those who truly deserve it. We very often see that people who are not very well to do are not even spoken to properly. We take them for granted that they are illiterate. Let us do what we want with them. We explain to them, this is your treatment, and we don't entertain their queries. Now, this is not something that is happening now. It used to happen, even probably still does, but now people are careful. So I think requires that you have a dialogue with them and they participate in their decision making, especially for research. There are instances where clinicians have told the research participant that you should participate in this research, because if you drop out or if you don't, then whenever you come to the hospital, you have to wait in line. I will not treat you. Free, and in this research, you'll get free medication. So that kind of inducement, incentive is different, but that kind of inducement then is unethical. Now, these are the general ethical principles, and all these general ethical principles are offshoots of one of the four basic pillars of modern day bioethics. Essentiality, when you do, and this is applicable to research, and most of them are even applicable to healthcare delivery. You will only do research or a procedure which is essential for the benefit of the patient. And the patient should be willing, patient or the research participant should be willing to participate in that research. It should be voluntary. You should take consent. There should be no exploitation of the research participant. Now, this exploitation started when the big companies from the West started targeting India, China, Brazil for clinical research, because it became very difficult and their research guidelines were very tough. Then number 4 and 12, which are in a different color, have been added in the latest guidelines of ICMR. Earlier, they weren't there. Social responsibility. It is the researcher's social responsibility to conduct research in a good way. It should be competent. The privacy and confidentiality of the patient when you're doing healthcare delivery, or the research participant when it comes to carrying out clinical trials or other research on human subjects. The data should be kept very confidential. Their identity should not be revealed. And there are times when you are doing work on records, you may not be able to consent the patient may not be available. Then you have to anonymize the data or make sure that the patient is anonymized and the identity is not revealed. It is the duty of the investigator or the treating physician or surgeon to minimize the risk involved in either research or in healthcare delivery. Incidentally, risk-benefit analysis is a huge topic by itself. It's a proper topic for a 1.5-hour talk. But all I'll say is when you're doing research, you have inclusion and exclusion criteria. So the members of the ethics committee get a very good idea. Even the investigator can get a good idea if he wants to make his research robust. To make the research powerful and strong, you have good inclusion criteria, very tight inclusion criteria, so that you remove all confounders. Like for age, sex, matching, you have a very clear-cut, narrow, standards. Exclusion criteria will minimize the risk. So inclusion criteria tend to improve the power of the study. Exclusion criteria tend to minimize the risk, because in exclusion criteria, you exclude people who are at risk of, adverse reactions from participating in that trial. So normally it is pregnant women and vulnerable people or children, etc. One thing that people tend to do is smokers and drinkers are removed from every trial. That is not ethical. Only if they will not be benefited by this trial should they be removed. Otherwise, there will be no trial which will benefit them. Even pregnant women, you shouldn't just cut, copy, paste the exclusion criteria. Pregnant women should be only excluded from trials which will be deleterious to their condition because they are a mother and baby combo. So there are some research protocols where the health of the mother or a pregnant woman is not affected. So they should be included in those. Then the persons who are carrying out research or doing the treatment should be competent. They should maximize the benefit to the patient because there are 2, 3 types of benefits. One is the direct benefit to a patient. The direct benefit is what the ethics committee looks at. Then there are indirect benefits. Indirect benefit may be to the society, or it may even be by doing research, you are adding some good and new findings to the corpus of existing knowledge. That also is a good reason for carrying out research. The totality of responsibility lies with the principal investigator. He can't say that, I have hired some staff and they messed up. Just like the surgeon or the physician who's treating, the responsibility is his or hers. Then for every research and for patient care, the institution should have adequate arrangements. And this is something which the ethics committee looks into. And transparency and accountability at all stages. And I think I'm coming to the ethics committee component somewhere later. Then I'll mention that the members of the ethics committee should also be very careful that if things go wrong during any research, they are also accountable because they have given permission for that research. Because their job is not just to give permission for the research, their job is also to go through the risk and benefit assessment. Their job is also to go through the compensation clause and make sure that they do a regular monitoring of the research. While the research is going on, the research ethics committee members should monitor the research. And a good way to do it is to check out how the investigator is doing the consenting. The consenting process, it's a proper process. It's not just where you get a signature. So I think and accountability is important. And environmental protection during research, you have to make sure that you do not damage the environment. And this is something which is in the latest guidelines. Now there are some general ethical issues. The general ethical issues are, one is benefit risk assessment. Now, benefit risk assessment is an outcome of your research. What are the possible risks that the patient has to be, subjected to? Now, like I said, this is an entire topic by itself because risk can be seen in 2 ways. One is an uncertainty. There is a possibility that this patient might have this issue. So uncertain, even like the market is risky. So it is just uncertainty. So one is the uncertainty, then there is a question of probability. So risk has to be assessed very carefully. And people talk of minimal risk as the kind of discomfort you would be faced with during your day-to-day work, etc., and exposed to routine physical and mental testing. Now, there are 2 flaws in this. One is nobody gets physically and mentally tested every day. Your routine day-to-day, you get up, go to office, traffic is a risk. Walking in rain, lightning, etc., may be a risk. So there are a few risks you undertake during your day-to-day activity. But then that depends on what you do. What about the person who's a window cleaner for skyscrapers? What about a soldier who's on the border? So the risk also varies in the population. So we have to be very careful in our risk-benefit assessment. Benefits are easier and they are established. Then privacy and confidentiality, which I already mentioned. Now, payment for participants of research is very, very crucial. If you are a multicentric study site, where the original site is, say, in the US, and they are paying $250 to a patient to spend an entire day in the hospital. So the patient comes in the morning, takes a cab, comes to the hospital. They are given money for, breakfast, lunch, dinner, and they go back in a cab. So their $250 will just about meet that. But if you give $250 to somebody in a third world country, maybe even in India, that's a hell of a lot of money. That becomes inducement. Because now people even who are not, who should not, people who have the risk of suffering serious harm from that drug or that intervention, they will hide their condition to participate because they're going to get $250 a day or every visit. It may not be their annual salary or monthly salary in some cases. So incentive versus inducement is something that we have to be very careful with. Then compensation for research related harms. Now there is one very interesting thing. Whenever a PI becomes, supposing you are the PI in an institution and a multinational company is doing the research and you are one of their sites, please make sure you read the clinical trial agreement very carefully. There are times you should go through there are legal experts in an ethics committee. They should also see the clinical trial agreement and warn the investigator. There is a possibility that the entire blame, if something goes wrong, may be on you. That is normally the wording of a CTA. So you should read that. Secondly, whenever you are doing research in an institution, so apart from the fact that you have seen the clinical trial agreement, make sure there is an insurance for the patients that you have enrolled. So then if something goes wrong, insurance will compensate them. And make sure that the insurance is for that title for the study. Like, for example, if a drug company called X, they can't give you that all the clinical trials being done by X are insured by this firm. No. If you are studying the effect on a drug called A on a condition called B, then the clinical trial, the insurance should be for a study entitled the effect of A on B. Site, it should name your site, your hospital, your city, and the jurisdiction of that insurance claim should be in India, not in some country abroad. So make sure that all the legal issues are well examined by the ethics committee. And that is why you have a legal expert in an ethics committee. Now, that having been done, people are scared to take on clinical trials because one, very few of them realize what is the definition of a clinical trial. If I don't say it, please remind me. But more importantly, there is a new, provision in the Indian ICMR guidelines, which is wonderful. It is investigator-initiated trials in academic institutions. So multinationals are funding all that. Okay, fine, compensation may go into lakhs, they may pay. But if a poor person in a medical college is doing a research, a clinical trial, and if there is an adverse event, and if it comes down to compensation, so either the institution should have some arrangement or there should be a group insurance. So those arrangements can be made within the institution, which will then prevent harm to the investigator. So the investigator, and because of the compensation clause, the institutional investigators, academicians may not want to do clinical trial. So now it is easy for them to do clinical trials, provided they follow institutional arrangements for compensation. Now, coming to that business of clinical trial. Normally, clinical trials are done on new drugs and molecules which people want to introduce in the market for a disease or a deformity or a, some condition, or it may be a device. Now, you need the DGCI permission, the Drug Controller General DCGI permission or SEDESCO permission to start a clinical trial. The other important thing is if you write, your ethics committee informs DCGI that so-and-so is doing a clinical trial, and within 1 month, if they do not respond, then it is taken as permission to go ahead. For institutional clinical trials, not for multinational driven clinical trials. Drug companies have to wait for the clearance, whereas in medical colleges, etc., if you do not receive permission within a month, that means you are given, it is granted, then you can take it for granted that permission is being given. Coming to the drug clinical trial, if you are using a drug, say paracetamol, which is a well-established drug, DCGI clearance is there for a particular set of conditions. So please remember, if there are any members of the ethics committee, you should also know, and the investigators should also know. If you change the dose of a drug, you decide that instead of 500, let me give 200, let's break half a tablet, let me see if this also works. If you change the dose of a drug for a specific indication, or if you change the route of administration, or if you change the formulation from solid, you make it liquid or injectable or whatever. So changing the route of administration, changing the dose for the specified indication, or changing the indication that this drug is good for fever, but we may also give it for something else. All this then makes it a clinical trial. And you have to then register in the Clinical Trials Registry of India, CTRI. And your permission, it has to go through an ethics committee. There's one more rule. Clinical trials can only be sanctioned by ethics committee that have been registered with the DCGI or CDSCO. Otherwise, you cannot process a protocol, research protocol, which is a clinical trial. A lot of people forget, or a lot of investigators in institutions are not aware that if they change the route, the dose, or the indication, it becomes a clinical trial. So please be very careful. And if there are any members of ethics committees in our group today, and if they are listening, please make sure that you ensure that the drug trial that the proposed by any investigator, it is not a clinical trial. Ancillary care for anything that may happen to the patient should be available in your institution. Investigator initiated and student research, I've already mentioned. I jumped the gun. Now, conflict of interest. This is very interesting and people don't understand too much. Conflict of interest is of two types. One is actual conflict of interest, where I am doing a research to promote a drug. Maybe I have bought shares in that pharma company for that particular drug. Or I'm doing it to gain money or fame. That becomes direct conflict of interest. Then there is a potential conflict of interest. Potential conflict of interest is that when you do something which might bring, it has not yet brought, but will bring. So that is a potential conflict of interest. For example, if I am the owner of a specific pharma company, and if I introduce that in my institution for a trial, and then I promote it and I make sure that the research goes on positively to say that it's a very effective drug, then there's a serious conflict of interest. And one very classic example of conflict of interest was the first ever death that was officially recorded for gene therapy. There was this teenager who died exactly at the age of 18. He just died on his 18th birthday, actually, when he was participating in a gene therapy clinical trial. This was being done by the University of Pennsylvania. And this was, this guy, his name is Jesse Gelsinger. If you can Google Jesse Gelsinger, he had a rare disease. It was this ornithine transcarbamylase deficiency. Now, this enzyme does not, allow you to process protein. Metabolism is defective. So the end products are not excreted. Now, he had a slightly milder form of the disease, which is known as mosaicism. So he had a mosaic gene. So he had a mild form. So with dietary control, with less protein in his diet and one cheat per month, he could have half a burger. With that, he was carrying on all right. So the university approached him that if you take part in this research, it may benefit all the people who have the lethal form of this disease, this ornithine transcarbamylase deficiency. So the poor chap, he took part in it and he died because the vector with which that was injected into him for the gene therapy treatment, he reacted adversely to the vector. And everything was all right. But what was not told to him during the consent, which came out later, was that the animal study regarding this particular vector had gone wrong. And that was not informed to the Gelsinger family. The second thing that happened was that the dean of the institution was involved in the company that was making that probe, the genetic probe. So there was a conflict of interest also. This became a huge case, and I can't say had the good fortune, because after losing the son, Mr. Gelsinger went around, and I met him actually in Toronto when I was doing my master's in ethics. He visited our joint center for bioethics. He spent a couple of hours with us, and he spoke to us about everything that had gone wrong in that gene therapy trial. So that was a father who'd lost an 18-year-old son on his 18th birthday. So that's conflict of interest. Distributive justice, we've seen justice in clinical trials. it starts from the participants being enrolled. You will only enroll participants in a trial who are truly meeting the inclusion and exclusion criteria, especially if you are paying them. Not your friends, not your relatives, not people who live conveniently close by. To benefit from the study, you should advertise either in newspapers or put out flyers. People should be able to benefit from your study, and people should be able to. Coffee enakku venumpa. Somebody is offering coffee. Anyway, so I think right from subject selection or participant selection, you should make sure that the resources you have are equally distributed with the participant. Or when you are doing healthcare delivery, the patient also deserves the resources which are in the hospital. With the exception that when there is one term known as futility of treatment, when you have a very terminally ill patient or somebody with severe trauma who has just been brought in, and irrespective of what you do, the triaging team realizes that this person nothing can be done, then it is futile to then invest resources in that person. So their futility of treatment is decided by a group of doctors. Community engagement: whenever you do any research, the entire community has to be engaged. They should be aware of it. It should be in public domain. And when you talk of tribal areas are all vulnerable. A quick word on vulnerable population: inmates of jail, children, then pregnant women, tribal, then people who are underprivileged, people from low socioeconomic group areas, people in uniform, police or military. These are all vulnerable population because they can be exploited for research. So in order to avoid or decrease their vulnerability, you have to augment your consenting process so that the vulnerability is decreased. And one more thing: when minors are vulnerable, but when they become major, their vulnerability changes, so consenting has to be done again. I'll come back to the process of consenting later. So one issue is in tribal areas, when you take a consent, you just don't go walk into a village and talk to a tribal person and start consenting them. You have to first go to the gatekeepers of the village or the society there, the panchayat or the village headman. Talk to them. Once he permits you entry into the village, then you can talk to the individual. Then the individual consent is very, very important. It happened somewhere in Bastar once. A group of researchers had gone in for some survey, and they were actually killed because the tribals there thought they were going to harm them. Communication of research findings, very important. If you have invested time and effort and money, and patient and subjects have invested their time, and you've done a research, and if you have not disseminated the findings, it is very unethical. Somebody has funded your project, or you may have funded it yourself or your institution. Research participants have participated. You have got some findings which you have not shared. So please make sure whatever research you do, it has to be disseminated, the findings. Post-research access and benefit sharing. If you have done a clinical trial and the drug has turned out to be a big success for the population on which you have studied the drug, or who have been your participants, and then you tell them now everything is fine, the trial is over, please buy the drug in the market, that is very unethical. And one big example, Siva, if he's still listening, he would know. In South Africa, it happened. Sub-Saharan Africa, when it was being decimated by HIV/AIDS, AZT trials were done. South African people had participated, and the results were very nice. And after the trial was over, the company walked off saying that now the drug will be available in the market. Then, of course, a huge hue and cry was raised, and all the participants who were part of that research and their relatives were given free drug. So that is the benefit to the participants for having dedicated themselves to this research. I would request you to read up the HeLa cell line. HeLa cell line is a very famous cell line which is very, very popular. Just about anybody who's working on cell lines has used HeLa cell line. It basically is an acronym for Henrietta Lacks, this black lady who had ovarian cancer. The cell lines were very robust. They were taken from her. And her family had no clue. Billions of dollars were made from those cell lines, but the family didn't benefit. Eventually, it went to court and all that. The family was, offered a little bit, which they didn't take, but it was at least, acknowledged that it came from her. There have been such instances, numerous instances where participants have, contributed tremendously to some research and benefit has been to the multinational company. So now it is known that any sample, anything that comes out of research, the researcher is a custodian. The ownership lies with the participant or a patient. Now, benefit sharing in group research, for example, if you're working in a village or someplace and you've done a trial on that entire place and some big things have happened, you can also give them benefit of potable water or opening a school in that village or giving them a transport or something like that. So these are all benefits that can be done. But these kind of benefits are something which you have, like direct benefits is the business of the ethics committee. Indirect benefit is not something which the ethics committee is supposed to consider. Now, what is the importance of bioethics? One is it's a mandatory requirement, so you have to do it. But human rights are often trampled, so it's a good idea to follow good ethics. It prevents you from doing something wrong, even unwittingly. Litigation is avoided. A lot of people go to court, but if you have done your documentation properly, and when I say documentation, consent is a different story. Consent is a process. The rest of it has all to be documented. The procedures have to be followed, and there may be policies, and there is a requirement by the guidelines. For 3 years after the trial, retain the original documents, soft copy or hard. And for high-risk trial, there are data safety and monitoring boards, DSMB. So make sure that you constitute a DSMB, and the ethics committee has the overview on the DSMB working. They can say, okay, this is a very high-risk trial. Apart from audio or video recording of the consent, you need a DSMB for it. So data safety and monitoring board can be made to avoid litigation. Then, of course, everybody is in the media glare. You have already advertised social domain. It is important for you to put your research there. So it's nice to have a proper ethical approach to healthcare delivery, to patient management, and to research, so that you avoid being in the media for the wrong reasons. Public awareness. Now, public is very aware. They all are Google masters. They see Google Mata and come to you, and they'll tell you a few things you may not know. So I think with public being so aware and alert, we need to be careful with how we conduct ourselves in the hospitals as well as in the laboratories. And then we are, majority of us working in corporate culture where it's not patient and doctor anymore. It's a client versus service provider. You charge them a good amount. So when you charge them, they require good service. And if they do not get good service, they sue. So like I said in the beginning, good ethics is good business. This is not my statement. I forget the lady who said it. Somebody from one of the major multinationals. It's not my statement. Ethical research should have value. It should have enhancement of health or knowledge, corpus of knowledge that I mentioned. One of the first conflicts, one of the important conflict that happens with researchers and ethics committee members is when the ethics committee tells them, okay, your sample size is wrong, change the study design, or give them some, advice on the research methodology. They say, no, we have been through the research ethics, through the scientific committee, and you do your job. Your job is only to see the ethical aspects. So let it be known, the first job of the ethics committee is to ensure that the research is scientifically valid, because it is unethical to do scientifically invalid studies where you have invested money, patient has been put at risk, and the results are now not generalizable because it was not a valid method. So the ethics committee has the right to point out any fault in the scientific study design or whatever else. And that is why there is always a biostatistician even in the ethics committee. The subject selection should be fair. This is distributive justice. It should be based on scientific objective, risks and benefits. That's the exclusion and inclusion criteria I was telling you about. There should be a favorable risk-benefit ratio. Independent review. Every research project should be reviewed by an independent ethics committee. And that is why the chairperson of all ethics committees are renowned physicians in the field. I'm talking about biomedical ethics committees. And they are not affiliated to the institution. And if, for example, now I am from AIIMS New Delhi, of course, seconded to Shillong right now. If I retire from AIIMS and tomorrow they make me the chairman of their ethics committee. That is not acceptable. There is a washout period. You have a cooling off period, like it happens for people in service. Because if I am associated with an institute and I am the chair of the ethics committee there, then there is conflict of interest. Informed consent should be duly informed and voluntary. I still have it written somewhere down in another slide, so I'll come back then. And autonomy, respect for the subject, this is something which you've already mentioned. In a research project, even if you're coming towards the end, you have done, say, 6 meetings, and you have to do a total of 8, and the patient says, a participant says, I do not want to participate. He or she has the right to withdraw without giving you any reason, without assigning any reason at all, and you cannot force them that if you don't finish this project, I'm not going to treat you in this hospital or whatever, etc. Now, I'll have a very brief. Vidya, how are we doing for time?
Yeah, actually, we have overshot a lot. So,
so should I leave the ethics committee component?
Perhaps, because I don't think we'll have any time for discussion. Otherwise, we are already.
So then we'll start discussion because most of the things I wanted to say, I have said.
Okay. Anything else after this? Any specific point that you wanted to make?
Let me talk about consent. Consent is something which is very serious. People go to court and they say, I have this consent document signed by the patient. Right. And the patient relatives say, we have never seen this man. He never came to the consent was taken by the. Normally the nurses go, they get a signature. Things are changing. I have even seen long back in the OT, patient is under anesthesia, surgeon asks, has he been consented? No. Then they run around, get a stamp pad, and under anesthesia, one LTI is taken just so that the paperwork is in order. Now things have changed now. People, you have to inform everything to the patient about the surgery that you're going to do or about the treatment that he or she is going to undertake or the research that is going to happen. And they have to be given a little time to think about it, come back to you with questions, answer their question, and then they consent. And then they write that I have understood in the language which was easy for the class 6 language, not technical terms. Minors have to be assented. So children between 7 and 12, you have to have oral assent and then parental consent. Children between 12 and 18, you have to have their written assent and parental consent. And when the child becomes an adult, you are working in a research project with a 17-year-old, and after 6 months on his birthday, he becomes 18, then you have to consent him again. So consent is a big issue. People who are not mentally competent should have a legally appointed representative or their sibling or spouse who will then consent for them. That happens even in patient. If you are brought somebody who is unaccompanied, injured, brought to the hospital, then the custodian or the guardian for that is the district magistrate. So the medical superintendent may consent and inform the magistrate. So these are a few things which you need to know. I think consent otherwise is a straightforward thing. Consent in high-risk research projects have to be video recorded and not on a phone camera. There are specifications for that. So I think I'm done with that. Unfortunately, we don't have clinical ethics guidelines. Slowly they are emerging and people go to court. Then there is, consumer protection, etc. So I think if we have good clinical ethics in place, then things will change a lot. Thank you for your patience. I think I'm done with this.
We have Professor Nandi, senior clinician, and also the editor and the purpose of journal. Sir, we'd like to hear from you, sir.
Let me introduce Professor Nandi. He is a very, very senior colleague and a luminary. Would you please unmute yourself, Dr. Nandi? You are muted. And I have had the pleasure of being with you at GTB. This is almost some 8-10 years back, University College of Medical Sciences, where we had sessions on ethics. And I was lucky I finished my session before you came on, because to bat after you have batted would have been absolutely impossible. One of the most renowned GI surgeons and researchers worldwide. Welcome, Dr. Nandi.
I think it was an excellent talk, but I have problems. One of the problems is that I don't believe, I don't know whether you read our editorial in the New England Journal, which says about a new neocolonialism that that you cannot do clinical trials in India. My feeling is that poor will try and please you and join the clinical trial, and the rich will think you're mad. And I think that as far as surgeons are concerned, it's a very difficult thing to have equipoise. And we've written on this recently that it's very difficult for a surgeon to say that, okay, I can do this operation as well as I can do another. And if I want to choose which operation is better.
Dr. Nandi, if I can just come in for a second for those who are listening, clinical equipoise is when you are not sure about A or B, which of them would benefit the patient. So true clinical equipoise would mandate to carry on with research. If you are already aware that this is better, so like he has very rightly said, for surgeons it becomes very difficult.
Yeah, for surgeons, it's practically impossible.
Absolutely.
And people, David Sackett and all the people have said that it is very difficult to do. And I think that it is very difficult to do. And we've done a study which shows that, but I do think that it is mandatory that one should do research in India because we produce so little papers. We tend to accept evidence which is generated in Western countries in circumstances which are very different from our own and which are not applicable. And I think that it's very sad that we did this study which showed that 57% of all the Indian medical institutions in this country hadn't produced a single paper in the last 10 years. I think it's very important just to try and find out answers to questions. And there's so many questions. But I think that your talk was very comprehensive. It should be written up and circulated widely.
Will do. Will do. And there's one more thing that people...
Thank you, Vidya, for the opportunity of being able to listen.
Thank you so much for staying so long, sir. Thank you so much. And Nalin, what were you saying?
You know, this business of patient autonomy also in some of our countries, in the West, it is one of the most important pillars. But people feel that since our social support is so much, we tend to discuss our issues in our families, even healthcare issues with our families and friends. So people have said that when you focus so much on autonomy, it becomes difficult for surgeons and physicians and even researchers to function. Whereas the person himself or herself may want to share some of the issues with the family members and friends. So we, you know, if I have an issue, I tell my friend, yaar, ye ho gaya, I'm having this problem, I have this issue, I need treatment. Can you suggest somebody? So we are open about our conditions. So there is that little issue about autonomy which the West pushes very much, whereas it need not be so heavily pushed.
And
But
what I'm very disappointed about in India is that 80% of people go to the private sector for medical care. And the private sector exists to make money. And it's very difficult for a person working in the private sector to be completely ethical.
We have Dr. Shifalika Goenka. Shifalika, your comments on what Nalin had to say, and I know we couldn't go through the whole gamut of everything. It's such a vast topic, so today you can take it as a curtain raiser or a teaser. But I'd like you to come in now, Shifalika.
First of all, I have to, give my regards to Dr. Nandi because I was a junior resident when I used to see him as HOD there, moving around the wards. So just such a privilege to see and hear him. And he continues, I think I see him the same, whatever, 30 years or 40 years back and what he is today. So it's a real privilege. And every word he said, and I remember the long tenure with the National Medical Journal of India, where he was the chief editor. So that's absolutely fantastic. Dr. Nalin Mehta's talk was absolutely outstanding. In that 1 hour, he's covered so eloquently and a synthesis of every aspect of ethics which one needs to take care of. And also the analysis in terms of the new additions to the ICMR guidelines and the differences about the law, policy, and ethics, and the futility of the treatment aspect, and the clinical dilemmas which physicians, especially in public hospitals, faces at each point in time. The conflict of interest aspect was really so beautifully brought out and with fabulous examples. And of course, the punch of good ethics is good business was kind of, I mean, it's such a true synthesis of the whole thing. And about the science aspect, I think that's the crux of all the ethics committees who become always the bad boys in all institutions. That why are you getting into the science, and poor science is ethical. I really wish that aspect had been more clearly written up in the ICMR guidelines, because that, I think, is the crux which all ethics committee members face. Now, coming back to, I think we should address the questions in paucity of time. And there are many interesting questions. Some of them have been answered by colleagues already in the chat, which I see. Of course, one of it is it moral or immoral to make money from other people's misery? So, Dr.
That
Mehta,
question answers itself.
So, if you don't mind, Shefalika, I'll like to call on Dr. Vijay Kumar, who's been, giving a lot of his comments and feedback here. Dr. Vijay Kumar, if you're still in the call, we'd like to hear from you.
Actually, he mentioned one of his questions was whether PG thesis trials also need registration. Every clinical trial needs registration with CTRI. In fact, I would go on to say, if you are doing any RCT, register it on CTRI, even if it's not a clinical trial, any research project, because it adds value to your work, and all the details of the ethics committee clearance, etc., are there registered in CTRI.
All right, Lata, you have your hand up. Did you want to say something?
Yeah, thank you, Vidya, and very nice talk, Nalin. My problem is, obstetrics. As you said, pregnant women are very vulnerable, but we definitely do need to do research even for small things.
Absolutely.
Especially when we come to randomized control trials. How do we go about? Because most of the times in our ethical thing, or even at a scientific level, they said no. What do we do? And these are necessary. And what happens is we end up doing only one-handed, single-handed research. Is like, instead of doing an RCT, we just go about doing one arm, and it doesn't get published. Well, how do we go about it? This is a major problem for us in obstetrics.
Like when you are talking about risk minimization,
yeah,
to include a person in a research trial, you have to minimize the risks as best as possible, which is done even for vulnerable population.
yes.
So half the problem is that the committee has become very obdurate. Pregnant woman, no. No, it's not that. If the committee says no, you can go to the appellate authority. When you can justify minimization of the risk and participation of the pregnant lady in the research, it is possible. There was a question about, can the chairman or secretary of the ethics committee sit over the committee to decide a part of his own project? Any member of the ethics committee, if they have a project which is being discussed, they have to step out of the room. It has to be minuted. If it is the member secretary, then he has to hand over, he or she, somebody else becomes the acting member secretary while this person is being discussed, this project. And if the chair steps out, even in the SOPs it is mentioned, if the chair is not available, does not attend, or has a project, then so and so, the next senior most member of the ethics committee will automatically become the acting chair.
Thanks, Lata. Dr. Venkatesh, you have your hand up. Did you want to say something?
Yes, ma'am. Extremely useful talk, sir. It's a fantastic narrative. As pointed out, the synthesis was extremely good. I have two questions, sir. Question number one, is there a whistleblower clause in case somebody during the research finds something is going wrong? Will this person be protected? Is it part of the ethical code which is written down? That is question number one. And number two is, I have a personal question. Recently, I had to take care of a patient where I found that the further treatment to this patient is futile. It's medically futile, and I was trying to tell the patient's family about it, but the patient family insisted that I should continue to treat. And it was particularly distressing to me to go on or persisting with the treatment, and I couldn't find another physician of let's say equal or with competence to take over the patient from me, and they continued, and I had to continue the treatment, and I was not very happy about it. What should I do in these kind of circumstances? What kind of
I'll take your second question first. If you have taken on a patient, then it is your duty to hand over eventually. Unfortunately, the patient parties do not understand when they, for societal reasons, for family visibility, they feel that they should do everything possible, even if it is increasing the misery of the patient. So you have rightly said, if you have explained to the patient party that any more treatment is a waste of money from your side and will not benefit the patient, it should very clearly be communicated. But if they are not listening, then unless you can request them to take the patient somewhere else. But you can't abandon if you don't have a replacement, unfortunately. And the first question was whistleblowers. See, whistleblower policies do not exist in the guidelines, but if there is a whistleblower and something wrong in a research comes out, then the institution will have to protect it. Even the court of law then protects them. Unfortunately, what happens in institutions is people try to put it under the carpet, anything that goes wrong, and then the whistleblower is made to shut up. And in big game trials, if there's a lot of money involved, even worse may happen. But by law, he or she is supposed to be protected.
Is that true in India, sir? Do we have that in India?
Yeah, there have been a few whistleblowers and a few trials that had been stopped, but we haven't had any major negative outcome to a whistleblower. Of course, they lose face in the institution where they are working because people become upset with them for speaking the truth. But that's lack of morality all around. So,
Dr. Shivam, you have your hand up. Did you want to say something, Dr. Shivam?
Thank you, Vidya, and hi, Nalin.
Hi.
What an evolution of an individual. Just to say that I was his junior in school days and then been in JIPMA campus and evolved over there. So
Nice to
awesome,
see you,
Nalin, and nice to really see that. I mean, my question, Nalin, was about this financial equality and equitability, or equitability, if you would like to use a word. Now, 80 to 90% of drug and devices come from the Western side, right? And then we exploit third world countries for research. How are ethical committees in, say, India or Indonesia managing to sort of enforce that benefit is being brought to them? It's in a way you look like they are being exploited.
Wonderful question.
Right?
A very good question. Two things here. When you talk of research, any drug or device that is given to a patient or a participant who is in a research trial is free of cost. So that is funded by the research funding agency. And for routine healthcare delivery in the country, the generic drugs are born, the Jan Aushadhi, there are multiple schemes. And there are multiple chief minister, prime minister, health minister, health insurance schemes. For example, in Meghalaya, where I am currently director of NIGRIMS, the health minister's health insurance scheme, the chief minister health insurance scheme take care of up to 5 lakh rupees. And majority of patients who are registered are totally treated free of cost.
No, my thing was during
the stents in the government e-marketplace, even the stents and all which are procured, they have brought down the cost to a specific thing. So I think.
Do you negotiate these things during the CTA stage itself to say that, look, as and when the trial is successful, we should have discounts and stuff like that?
Post-trial benefits is, that is done a priori.
Okay, good. Thank you.
Can I come in there, Vidya, because it's something that must be understood also.
Yes, Shiva. Yes, Shiva.
Sure. There's another thing that is there. If I look at the Constitution of India and even South Africa and even now, the WHO is going into this also. It is coming to a new process. It says, do not link the cost benefits of research and other things to what your procurement policy should be. Every country should have its own procurement policy, which ensures that it brings drugs or equipment or instruments or medical equipment devices to its citizens at a cost-effective manner. In that sense, what people do not know is that Tamil Nadu Procurement Board is leading the world. It's a Harvard study about how procurement should take place. And what people do not know is that the Tamil Nadu Procurement Board is now the procurement board for Malaysia, Singapore, and 4 other countries, including Mauritius. So what you have to do is that irrespective of the research, your country should make legislation to ensure that you are not exploited by patency, you are not exploited by other mechanisms, but make sure that your citizens get access to drugs and devices in a cost-effective manner that is equitable and fair, and not be caught up by patency and market-related issues. I hope that answers.
Absolutely.
Dr. Vijay Kumar, you have your hand up. Did you want to say something?
Madam, Madam, I just missed. Were you asking me a few minutes ago about something? About the discussion?
No, I just wanted to know whether you had something to say, because you were typing a lot of comments on the chat box. We thought we'll hear from you directly, sir.
Ma'am, I am a member secretary of my college, Kakatiya Medical College. So there are about it is not the pure this thing. Again, PG dissertations, we have a tough time. Some researchers come with a frank straight trial and they say, what is this thing? Why we should register? It's a pure academic thing. This is the tough thing that go. This particular lecture has helped me a lot to handle my colleagues who even if they are serious. Thank you very much, sir, for the discussion. This is what I wanted to say.
Thank you.
Thank you. Shefali, I lost track of some of the comments. Anything that you wanted to address among the questions or comments on the chat box? Okay, somebody has asked if there is a separate portal in CTRI for PG dissertation.
No.
Okay, right.
CTRI requires your title, researcher's name, ethics committee details, so it's common for all.
Right. So there's one question about about doctors' rights to refuse patient requests for certain treatments.
Yes, that can be done. And this has to be informed to the patient and to the patient's attendants in writing that this is something which I don't do. Because patient values, when you are talking about doctor-patient relationship, there are basically 4 models. The paternalistic model is now abandoned. There is the interpretive model, the informative model, and now there is the deliberative model. In the deliberative model, you will inform the patient, because in the informative model, you have to take care of the patient's values. For example, if the patient has some religious beliefs and they do not take anything which has anything to do with the, say, either porcine or bovine, those kind of things. So those values, it is imperative upon the doctor to take care of these things. Whereas in the deliberative model, you can tell the patient that these are my values, and then it is your duty to give them an alternative.
Excellent. Are there more questions?
So KK has commented when we were talking about whistleblower, KK has commented that he was specifically asked to state about a whistleblower policy for a recent trial. So it's going to be part of the, guidelines for trial from now on, I guess.
Absolutely.
Then,
see, whistleblowers, when the ethics committee is monitoring the case, you may listen to whistleblower. If the ethics committee gets something in writing, then they can stop a trial. There have been whistleblowers not treated too well, and some whistleblowers very well protected by law. So it's a very interesting place. It just depends on the amount of money involved. There are whistleblowers who've been, terminated. So
Vikrant Mohanty, if you're still on the call, you also shared a lot of links. Anything particular that you would like to highlight among the information that you've shared?
Thank you so much, ma'am. And I thank Professor Nalin Mehta for this eloquent talk. And I think he's given a lot of clarification, very specific clarification in terms of ethics as well as ethical research being conducted in institutions. Or whatever I have shared is in terms of whatever discussions were happening, just to add on to whatever Dr. Nalin was saying in terms of the different aspects of biomedical research. Thank you so much, ma'am, for the opportunity.
thanks, Becky.
There are some more questions in the chat. How to have access to ethics committees for research in a private hospital? I'll rattle off some of the questions in the interest of time. And what about patients' duty, like regular follow-up and compliance? And separate portal for CTRA registration for PG dissertation?
There is no separate registration portal. When it comes to research ethics committees in private setup, no matter whether you're a government or a private or NGO or a trust or a public-private partnership, if you are going to carry out research on human subjects or on animals or stem cell, or you have to follow the appropriate guidelines, and those have to be reviewed by a committee. If you do not have your committee in your institution, which may be very small or a small clinic, then you can have an MOU with a bigger hospital close by or an academic institution, and that MOU will say that your ethics committee will look after the projects out of this clinic. And if it is a clinical trial, it has to be a registered committee. Nowadays, it is mandatory for everybody to have a registered committee. And second thing was the patients. If a patient is not bothered about coming back for a follow-up, the patient may be informed. If they do not, and a lot of them are lost to follow-up, there is nothing you can do. It is not unethical. If the patient doesn't want to do it, he or she has the right to do whatever they want. They can even refuse treatment, even treatment for something which will be fatal if they don't take it. So that right the patient has.
And ethics committees for private hospitals?
Yeah, they should. If they are carrying out research, they should have an ethics committee, a proper registered ethics committee. If not, they can have an MOU, like I said, with another institution to handle their things.
Right. And there are some hands up also, ma'am.
Prasad Pore, would you like to say something? Your hand is up.
Yes, am I audible?
Yes. Yeah.
Madam, there is a separate portal for PG dissertation in CTRI. I shared that link in the chat box. In the Google, if you just search the CTRI, you will get that link also. Because a few years back, one of our PG students has registered her clinical trial in PG dissertation. It was her PG dissertation topic in CTRI. So as far as my knowledge, there is a separate portal is there for PG dissertation. I shared that link in the chat box. So just can go and guide us regarding that.
Thank you for the information.
Thanks a lot, sir. It was a nice, wonderful session, sir.
So I have just reshared the link once again.
Oh, thank you so much. Thank you so much. Ravi, you have your hand up, Ravi Shankar.
Yeah, I just wanted to say, about patients' compliance with research protocols, etc. Obviously, nobody has control over that. And Nalin's response was absolutely right. They have the final right to do what they want to do. Typically, in most clinical trials, those things where the patient is not compliant despite repeated requests, or doesn't follow through with what needs to be done in terms of, say, they have to check their blood sugars every day or something like that, they don't do it, they're typically reported as protocol deviations. And towards the end of a study, the number of protocol deviations is also one of the things that's used to assess the quality of that particular study. Protocol deviations are reported to most regulatory agencies. And so it is something that's very important. And same thing happens. I mean, protocol deviations just don't happen, not just with patients, but when investigators deviate from the protocol, etc. So, and a priori, before patients are enrolled, the list is defined. What are important deviations, what are not important deviations, and of the important deviations, what are clinically meaningful versus those that are not, etc. So they're all defined ahead of time. Sometimes we change them during the course of the protocol because somebody does something that we've not thought about before. But essentially, they are handled via protocol deviations and not through any sort of ethics violation.
Yeah, thanks, Ravi. I think some of the people who raised that question were also talking about it in the clinical scenario. Can you refuse to treat a patient who's non-compliant? I think that's the summary of some of the...
That has to be documented, recorded, and then conveyed to the patient and the patient's relatives and handed over to somebody else if required. And coming to that business about deviation from protocol, any deviation from the established protocol has to be reported to the ethics committee, including if you want to change the PI or a COI, or if you want to add another person, or if you want to reduce or increase the number of parameters that you want to test from a blood sample which you have taken. Any variation has to be documented and informed to the ethics committee, and the ethics committee doesn't usually refuse them unless there is an issue with patient privacy or confidentiality or other.
Yeah. Dr. Venkatesh, you had your hand up. You were going to ask.
Yes, ma'am.
Yeah.
Sorry, ma'am. Sorry for keeping you all late. I have just one more question.
We still have time. We still have time. Yeah.
One more question, sir. This is pertaining to transplants. Recently, there is a general reluctance amongst nephrologists to accept unrelated donors for transplants, purely because once a transplant is over, and if there has been some kind of commercial transaction between the donor and the recipient, and the aggrieved donor goes to court and makes the hospital also party to it, it becomes a problem. But recently, one of the patients had actually gone on and got a court order saying that the hospitals cannot refuse unrelated donors for transplantation. How to wriggle out of this kind of situations?
See, the business of unrelated donor transplant is a very long drawn one. To get permission from even the court of law for an unrelated donor, once it is done, and if you're offering that treatment, then you cannot refuse treatment to a patient. If a patient that you offer a facility, and if you are offering that to somebody and refusing that to somebody, then it becomes unethical. May not be criminal, but then people can get you into.
Yeah, thank you. Thank you.
Yeah, Shifalika, do you have anything to add on that?
But one thing I think
point is that this is
where he was where he was coming from probably was with related donor. It's a family member, so legally you are safe. Probably what you meant was that it's an unrelated donor. They may blame the hospital for doing some shoddy thing. That's not true, because even for unrelated donor, the court there is a very long drawn process for getting permission for an unrelated donor to be able to donate their organ.
No, having got the permission, having got the, there are various ways for that.
After that, you cannot refuse. If you are offering that facility, it is not fair to refuse.
Basically, the question is the unrelated donor goes to a state authorization committee, and the committee says, okay, you can, this is truly altruism, and gives the hospital permission to go ahead with the transplant.
Yes.
But later on, the problem happens with the donor and the recipient, and they go to court and make the hospital and the surgeon and the nephrologist party to whatever has happened. And it results in the authorization committee at that point of time says that it is a responsibility of the treating doctor to figure out whether there has been any money transaction between them or not. So that is the reason why most of the nephrologists actually would not want to accept an unrelated donor.
You can get an affidavit from the donor and the recipient before. There are ways to safeguard. You get a good legal opinion and get it done. Because SOTO, like you said, the state the transplant committee, they may not delve into it. They'll just leave the baby with you.
Shifalika, did you have anything to add on any of these points?
No, I think excellent points have been made, and I just thought I'll bring in a little student perspective, because I mean, all of us, especially the clinicians, have MD and DM students. So what I tell the students is that the ethical considerations come at the time you conceive your idea. Because if your idea is unethical, then your design and everything becomes unethical, and no amount of correction can put that in. And for that, I tell the epidemiologists that you'll talk about placebo-controlled trials. That's the gold standard. And every student is thinking of placebo-controlled trials, and they are no longer being done. I mean, this should not be done when there is another arm of treatment. So the concept of clinical equipoise. So start ethics at the stage.
Now, what has happened is if there is standard of care, then people say, how can you have a placebo when there is a standard of care?
Exactly.
It's becoming difficult, more and more difficult.
Exactly. So that's it. An excellent talk by Dr. Mehta, and his knowledge is phenomenal. Phenomenal. That's all from me. Thank you, Vidya.
Thank you.
Radhakrishna, we are almost ready to wind up.
And Vidya, can I speak something?
Yes.
Oh,
yes,
lovely
yes,
to see Gitanjali. Hi, Gitanjali.
Yeah, hi, Nalin. Thank you very much. I enjoyed your
I
talk.
thought you would offer to join as a moderator.
No.
Gitanjali is a busy lady now. Busier
Nalin,
than
thank
earlier.
you very much. Thank you very much. That was a great talk. But I just want to bring in something which I think all of you are familiar. See, when there are more than 700 medical colleges and almost nearly not completely, but almost 1 lakh PG seats. And all those postgraduates, they do MD, MS dissertation or DM. Or there is some research which is going on. Less than 10% gets published, right? And what happens is when you see the kind of topics which are being taken up, even your first point, whether this is a valid, whether the research is valid, are you asking a valid question? That is not there. After it is done, it is not published. So what is happening is this huge amount of work which is being done, we are asking, which is repetitive. Nobody actually wants to know. There is a lot of fudging and things which go on. And so I think it is time that we people wrote to the NMC and said, please take a look at this, because a huge amount of unethical work is going on.
I'll take it up. I'll definitely take it up. I agree with you.
When people can actually focus on doing something good and, doing good research.
There was one institution where the PGs had gone to another city, visited a medical college library, copied the entire thesis and submitted. This has also happened.
Yeah.
Can I add something to this? Okay, after Madam, after Dr.
No, I'm done. Thank you.
No, ma'am, I agree with you totally. But the problem is in JIPMA itself, we have 75 PGs in one particular department. And thesis topic have to be something which has to be done within 1.5 years. Okay, and where will we get the novelty? Where will we get the patients? Where will we get the topic?
Oh, you're right, Lata. Actually, there was a point in time when there were very few colleges and few PG research was well worth it, and people were to take a risk. Now with this, we are propagating cheating, plagiarism, because there is nothing new to do. So we should go back to that old model. Once upon a time, there was an option. You either do a thesis or you do a case recording of some 20 or 30 major surgeries, which at least will make you competent in your field. I think this matter I'll take up with NMC. Good idea.
Yes.
One particular question was missed. Rajesh iPhone had asked, status of do not resuscitate in India, any ethical implications?
No, DNR, any patient end of life issues are very, very, complex. But if there are already instructions given, do not resuscitate or intubation is not to be done, etc., they have to be respected, followed. But make sure in your institution or hospital, wherever it is done, it is documented, the patient's relatives, you ask them to consider, reconsider, and then write it. DNR, the patient may have given at the time of admission. You have to respect them. And on those beds, the DNR poster should be there so that the patient is not resuscitated. It's safe, but the documentation is important.
Yeah, like Shivam has mentioned, I think as a student, learning research methodology is more important rather than doing something novel. So
Absolutely.
probably that time can be spent well in trying to understand research methodology and actually analyze some good papers or go through the process or even shadow somebody who's doing a clinical trial or something like that. So
Very, very true.
yeah, over to you, Radhakrishnan.
Wonderful lecture, I should say, Nalin. I'm really, really impressed. Every word, every sentence made a lot of sense. And you are given the purest form of orange juice instead of giving us oranges. You know, I wish I heard this lecture 30 years ago. I would have been a lot better clinician. And, you know, I think the very credit is that Dr. Samranandi remained for the longest period of time listening to what you spoke. And that speaks volumes of what you, I mean, the value of what you spoke.
I've had the
Now,
pleasure of being with him on a couple of occasions where we have done our lectures. And like I said, I'm glad I spoke before him, because to speak after him, then you are suddenly, you know, the Gavaskar has batted, Kohli has batted, you go in and people leave.
I understood something called ethics in medicine only after I joined his unit and worked under him, and that has transformed a lot of us. My worry again, as I keep saying all the time, is how will we carry this message to the just joined MBBS and the undergraduates? They should understand this much more than anything. And then finally, the thing that keeps worrying me all the time is I think we clinicians face ethical problems with each and every patient. The first patient I saw this morning is an 80-year-old with a massive liver malignancy, pulmonary metastasis, and I told the relatives, don't do anything. The ideal thing is that he should see a medical oncologist, and unfortunately in corporate sector, they will do a PET CT, then they do a biopsy, and then put on medication, which I didn't want anything. I don't know what what he did is
All he needs
ethical
is
or unethical.
palliation.
Yeah, I don't know. As you rightly said, there's some ethics in clinical guidelines. I don't know when will that come, and there are too many clinical guidelines in an Indian context. Altogether, wonderful, wonderful lecture. I'm really, really
Thank you, but
impressed,
thank you
Nalin.
so much, Radhakrishnan. Thank you.
I think Vidya, with every week, I think topics are becoming better and the speakers are becoming better. This is my time. Yeah.
Yeah, so
actually, I'm so glad to get your
But
positive comment, because I thought I had not done justice to consent. I had not done justice to benefit risk analysis.
Another session,
One out of
another session, definitely, Nalin.
bioethics part 2 done.
Yeah.
I,
Shifalika wants to say something.
I just want to say that never have I heard a session in such a short time, such luminous and brilliant communication of ethics, both in clinical and in research ethics. It was absolutely stupendous.
Thank
Superb.
you.
It just shows the decades of synthesis of knowledge and practice.
Thank you so much.
Privilege, yeah.
So like someone said on the chat box, it came from his heart directly to the listener's heart. So it's definitely not cut and pasted from anywhere. So thank you, Nalin. Maybe next time we'll reconsider to have a subset of something so that we can have more discussion and.
I hope your invitation still holds, Nalin.
Oh yeah, RK.
Vidya,
Whenever.
if Giri finds time other than marriages, he'll join us as well.
Definitely.
So,
Yeah, I'll join.
And Krishna Kumar actually put a post. He's left, but he said that this recording should be, played in every bioethics class or for every session on bioethics. So yeah, we'll get the recording across, and then it's up to people how they use it, I guess. So Nalin, we'll come back to you. Radhakrishnan and I will come back to you about our. As of now, very grandiose plans of Marvelous Medicine Roadshow.
Please come
so
over.
definitely, Shillong will be one of our destinations.
Thank you.
Thank you, everybody. We had over 85 people logged in today, and so many of you still here even after 1.5 hours. Thank you so much for an extremely interactive audience. And thank you, Nalin, for keeping everyone together for more than an hour. Good night, everybody. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe.